dear audience. My PhD topic is procalcitonin guidance for optimal antibiotic therapy in critically ill patients. My name is Márton Papp. I'm an anesthesiologist specialist in Budapest St. John Hospital. My vision is that unnecessary and inappropriate antibiotic therapy will be a bad memory from the past one day, and my mission is to protocolize and individualize procalcitonin use in ICUs. Here you can see my specific goals. My first goal is to investigate the effects of procalcitonin-guided antibiotic therapy versus standard treatment in ICU patients with the methodology of systematic review and meta-analysis of randomized controlled trials. The problem is that inappropriate use of antibiotic has numerous adverse effects like growing antibiotic resistance, which caused approximately 700,000 deaths worldwide in 2014. But, on the other hand, the current sepsis guideline recommends us to give early antibiotics, ideally within 1 hour of the recognition of the septic patients. We know that we can reduce the duration of the antibiotic treatment with a median of 2 days from previous studies, but it is still unclear when to start or stop the antibiotics safely and whether this PCT-guided management can serve this purpose. So our aim was to investigate the efficacy and safety of this PCT-guided management versus standard therapy on appropriateness and length of antibiotic therapy. Our clinical question was that does procalcitonin-guided antibiotic therapy reduce the length of the treatment without causing harm in ICU patients? So patients are adult ICU patients treated with antibiotics in the ICU. The intervention is PCT-guided antibiotic therapy, which means a predefined PCT protocol for starting and or stopping antibiotics, which is a strong recommendation for the clinician, compared to the standard of care without PCT guidance, and our outcomes are length of the treatment, mortality, recurrent and secondary infection, length of stay, and cost. And the hypothesis is that this PCT-guided antibiotic therapy reduces the antibiotic use without compromising patient outcomes compared to usual care. And with decreasing antibiotic use, we can decrease the antibiotic-associated adverse events and even healthcare costs without serious adverse effects. We conducted our systematic search in the 3 main databases with this search key, and after the selection we have 26 articles for the quantitative analysis, which you can see here. Our primary outcome was length of antibiotic therapy. The outcome measure is mean difference in days, and you can see that in the PCT-guided group, the antibiotic therapy is decreased in nearly 2 days, which is clinically relevant and even statistically significant. You can also see the results of the risk of bias and the grade assessment depicted on the relevant plots. 28-day mortality is seen in this plot. The outcome measure is odds ratio, which is 0.84, which means that in the PCT-guided group, compared to usual care, the odds for 28-day mortality is 16% lower, which is also clinically relevant and statistically significant. Because of the changing sepsis definitions, meaning that the sepsis 1 and sepsis 2 use the more specific systemic inflammatory response syndrome plus infection equals sepsis criteria, which means a tachycardic febrile patient with infection was considered as septic. The new sepsis 3 says that sepsis is a life-threatening organ dysfunction caused by a dysregulated host response to an infection, and the emphasis is on the organ dysfunction, which is defined as an acute change in the so-called SOFA sequential or sepsis-related organ failure assessment score with 2 or more points, which reflects an overall mortality risk of approximately 10% in a general hospital population with suspected infection. So in this more ill population, length of antibiotic therapy was even more decreased with 3 days. However, this result is not mathematically significant. But if you look for the 28-day mortality in the sepsis 3 subgroup, the mortality is nearly halved in this patient population. Speaking about safety, rate of recurrent infection, which is an infection caused by the same pathogen in the same location as the first one, we can see here that in the PCT-guided group, the odds is increased with 1 times higher in the PCT group. But if you look, the overall event rate was quite low, below 5%. Speaking about secondary infection, which is another infection, in most cases, multi-drug-resistant organism-caused infections, there is no difference between the two groups. The length of ICU stay is decreased by nearly 1 day, and the length of hospital stay is decreased by nearly 1.5 days in the PCT-guided group compared to usual care, which is clinically relevant, but neither of these results are statistically significant. The strength of our analysis is that we used only RCTs with a high number of patients and high number of articles, and we are the first to analyze sepsis. So of course we have several limitations with the high heterogeneity, different degrees of protocol violation, lack of reporting on antibiotic appropriateness, and exclusion of immunocompromised patients. But at the end, we can say that we can reduce antibiotic use with PCT guidance, especially in those regions where routine antibiotic administration exceeds 7 days. However, PCT guidance is accompanied by a higher rate of infection recurrence, but despite of that, it is associated with a lower 28-day mortality. So our data provides a strong support on the use of PCT guidance in the antibiotic therapy in ICU patients. But of course, we have implications for research. We need RCTs with PCT protocols for starting antibiotics because we have a few of them, and we should use organ support 3 days as outcome rather than mortality. We submitted our article in the critical care in July, and now we are waiting for the editor's response after the reviews come back. And as I mentioned, we need RCTs for starting antibiotics using PCT. So our second goal is to investigate PCT kinetics to guide antibiotic therapy of ICU patients with suspected new onset infection. The problem is that more than 50% of ICU patients are considered as infected, and we know that the infection can more than double ICU mortality. On the other hand, less than 60% of our ICU patients with an initial diagnosis of sepsis are later confirmed to have infection. So the differential diagnosis of infection and sepsis could be quite challenging. We know that procalcitonin is the best known sepsis biomarker, and we can use it even after prolonged ICU stay, and we can use absolute PCT values or the kinetics of procalcitonin, but we don't know which one is a better predictor of infection. Therefore, our aim is to investigate whether antibiotic initiation guided by PCT kinetics can decrease unnecessary antibiotic therapy compared to absolute PCT values or no PCT at all. The question is that can we decrease the use of clinically unnecessary antibiotics with the help of PCT kinetics in ICU patients? Our patients are adult ICU patients with suspected new onset infection. It's a 3-arm study. Intervention 1 is antibiotic initiation guided by PCT kinetics. Intervention 2 is antibiotic initiation guided by absolute PCT values. And the comparator is antibiotic initiation without PCT guidance. And our outcomes are under discussion, but mostly rate of unnecessary antibiotic therapy, rate of recurrent infection, organ support 3 days, ICU and in-hospital mortality, number of multi-drug-resistant organism-caused infection, cross-ciliated difficile infection, kidney injury. And our hypothesis is that using PCT kinetics can reduce the rate of unnecessary antibiotic therapy without compromising patient outcomes compared to using absolute PCT values or usual care only. And the implication is the same as before. We should recruit adult ICU patients without septic shock defined in the surviving sepsis guideline with suspected new onset infection on ICU admission or during the ICU stay. When the source of infection is known or highly suspected, with 2 PCT values available, one on the day and one before 24 plus minus 4 hours, and microbiology sampling has been done. And we should exclude patients with septic shock, with infections, which long-term antibiotic therapy treatment is strongly recommended, for example, infective endocarditis, when infection is related to a primary surgical intervention, when the adequate source control cannot be guaranteed, when the chance of survival is poor, admission after cardiopulmonary resuscitation, patients with immunosuppression, non-pregnancy, and patients on antibiotics within 72 hours before inclusion. Now we are in the preparation of the protocol. Here you can see the overview of my 2 goals, and my quote: "He who fights can lose, he who doesn't fight has already lost." Thank you for your attention.
Thank you very much. We have time for a couple of questions. Thank you for this nice presentation. I'm curious that and PCT, if it's combined with the CRP levels, is it maybe superior than only the PCT, or there is any data for that, or there is no actually data?
We can say that in some ways it's superior because procalcitonin has a better kinetics. It has a very fast response time. After the infection and the interleukin levels rises, PCT rises, and it has a very well-known kinetics that it rises until 24, 28 hours. And if the infection is under control, it stops and starts to decline. And we know very well the half-life of PCT, and we know from everyday practice if the antibiotic therapy is good, nearly every day we have a halved PCT value. CRP is not that fast. It rises later, and it is very important because you have to get the infection as soon as possible and give antibiotics. So I think that PCT is better in that way, and we should use it more precisely.
Right, in this way, that the PCTs can assign the severe patients more quickly. But if we examine the two parameters or two molecules together, maybe the CRP can indicate the end of the treatment, and maybe there's no necessity for such a long antibiotic treatment, as you mentioned, that the PCT in alone, to measure PCT alone, requires much longer antibiotic therapy, which is not even necessary, and sometimes the recurrence of the infection is more frequently. And maybe the combination of with the CRP, maybe it can decrease this recursion of the...
Yeah, you're absolutely right. The problem with CRP that is not that specific for infection. It's an acute phase protein. But of course, like in other situation, we can combine biomarkers and it could have added value. So yes, but the current guideline recommends a week recommendation, procalcitonin and clinical evaluation for stopping the therapy. There is no mentioning about CRP in the guideline.
Mm-hmm. Okay, thank you. Anybody else?
It's rather a comment. If I'm not mistaken, you said that you excluded the immunocompromised patients, right?
Yes.
I strongly recommend not including them, but to investigating them separately. Because
you're right.
Interesting question, and I think that the added value could even be higher in that.
You're absolutely right, because this is one problem in the previous RCTs that they all excluded. This is why I said that this exclusion criteria is even under discussion at the moment. But yes, thank you.
That fact should be investigated separately.
Yeah.